So today is my pleasure to introduce Professor Anna Yaroslavsky from the University of Massachusetts at Lowell. So she is a professor of physics and the director of the Advanced Biophotonics Laboratory, ABL, at the UMass Lowell. And she's also a visiting scientist at the Department of Dermatology at the Massachusetts General Hospital. So her research at the ABL focused on the development of light dosimetry and explores multimodal approaches for functional and structural characterization of biological tissues. As a visiting scientist at the Mass General Hospital, she conducted translational research aimed at the development of optical methods for pathology detection and treatment monitoring. So Dr. Yaroslavsky had published many papers in top-tier journals and has been issued a number of patents. And she also served as a reviewer on the NIH and ASF panels, and also being elected the fellow of Optica and also of SPIE. More information could be found at her website at UMass Lowell at ABL. So now is my pleasure to introduce her and for her to give the talk to the audience. Thank you.
Hello, should I start sharing screen?
Yes.
Hello, I'm really excited to be here and thank you for a very nice introduction. Today I will be sharing the results and insights in our research on the translational potential of optical polarization imaging. And by translational, I mean clinical translation. So everything we do in my lab is aimed at trying to translate optical and other technologies into the clinical use. So I would like to start by thanking all of my former and current graduate students, undergraduate students, and research fellows. I would like to thank them for their dedication to the research conducted in the Advanced Biophotonics Lab and for their hard work. As was mentioned in the introduction, research directions in the lab are quite diverse, but all pursue the same goal. We are studying light propagation in the biotissues, and the goal of this direction is to enable dosimetry and to learn mechanisms of light treatments, such as photobiomodulation therapy, interstitial thermotherapy of cancers, laser lithotripsy, fractional laser treatment of osteoarthritis. These are a few of the current projects that are pursued in the lab. We are also working on morphological and functional multimodal imaging, and we are looking at functional and structural assessment of tissues, working on delineation of cancers, and looking at trying to find cancers in single cells. Initially, I was hoping to cover everything that is now highlighted in purple. I was hoping to go over our optical polarization imaging project, as well as our fluorescence polarization imaging projects. However, I quickly realized that it's too much, and today I will be focusing mostly on optical polarization imaging, which is macroscopic imaging, and it is performed in the reflectance mode. I will not go over fluorescence polarization imaging, but I have several slides, and if you would have any questions or interests, I can share them with you. So First, I will start on using optical polarization imaging for quantitative, non-invasive, and rapid assessment of dermal collagen. So let's start by looking at the structure of human skin. As you can see, it has several layers. The outmost layer is stratum corneum, and it is usually quite thin and consists mostly of dead skin cells. Then we have epidermal layer, which has basal cells, squamous cells. It also has melanocytes. Usually it has a thickness of approximately 100 to 150 microns. And then we have dermis, and this is the layer that is between hypodermis, which is fat, and epidermis. And this layer contains collagen. And collagen is the predominant structural protein found in the skin. That's what we will be visualizing. Now, here is more detailed structure of collagen. First, we see collagen fibrils, which are between 100 and 200 nanometers in size, and they can be visualized using electron microscopy. These fibrils are bundled into collagen fiber, and this is what we usually see when we look at processed histology. And then there are bundles of collagen fibers, which are between 60 and 200 microns. And this is what that is what we're visualizing using technologies such as confocal microscopy or second harmonic generation microscopy. And also that's what we will be looking at with optical polarization imaging. As I already mentioned, collagen is the most abundant protein in skin, and it forms 3D lattice-like structure in dermis. It provides elasticity and tensile strength, and that's why it's quite important for the integrity and functioning of the skin. Current methods to evaluate content and structure of collagen are quite limited, and in the clinic, it's histopathology. So you can perform immunohistochemical staining for collagen, and you can see here different types, type 3 collagen and type 1 collagen. Everything that is brown in the image is supposed to be collagen. The limitations of histopathology are quite obvious. To perform such an evaluation, you need to take a biopsy, so you need to take a sample of skin, and that's not always possible, or that's not always desirable. And biopsy in general can cause scarring and infection. There are other methods such as confocal microscopy, and here you can see RCM, reflectance confocal microscopy image, and this is a mosaic image. This is a very versatile method, but it has certain limitations such as small field of view. It's usually under 1 millimeter field of view. So if you would like to evaluate consecutively the same part on the human body, it may be challenging to find the same exact spot. And if you would like to perform mosaicing, which is possible, it is time consuming and quite sensitive to the motion. On top of it, it is comparatively expensive and requires laser exposure to the skin. Optical coherence tomography is also an option, and it is similar in a way to confocal microscopy, but it's really difficult to resolve collagen bundles, as you can see in this image. And this method is also comparatively expensive. Second harmonic microscopy can give a lot of detail, and you can see here basically this tiling, which is mosaicing. It has similar limitations to those of confocal microscopy, and even higher power density is required to obtain such images, and it is even more expensive than confocal microscopy. Now, we have proposed to use optical polarization imaging to visualize collagen, and this is based on actually accidental finding. At some point long ago, I was funded by the NIH to delineate non-melanoma skin cancers intraoperatively, and we used exogenous contrast agent to do so. While imaging, we realized that we can see a gauze-like, lattice-like structure in the images, even through the epidermis. And when we looked into it, we realized that's actually what we are seeing is collagen. Here you can see a picture and optical layout of the device that enabled us to discover that we can image collagen through intact epidermis. It is very simple, and you can see on the right-hand side, it was quite bulky. It used xenon arc lamp and interference filters to deliver light, and CCD camera to acquire images. Everything was controlled by a computer. Optically, it is quite a simple layout. So you have an illuminating fiber optic ring, which is coupled to linear polarizers. So the object is illuminated with linearly polarized light. Then we had linear polarizer attached to the lens of the CCD camera, and this linear polarizer could be rotated so that we could orient it in any desirable direction with respect to the polarizer on the illuminating ring. And this kind of device provided us intraoperative images. So the resolution that we could get was on the order of 12 microns, which is quite good. The field of view is big, so it's macro imaging. So it was approximately 22 millimeters by 16 millimeters. And as you can see, the power densities are quite low. So it's on the order of 0.4 milliwatts per square centimeter. On top of it, it's very rapid image acquisition, and basically you can see the results almost as you image. Now that's a closer view of the device and how it can be used specifically for imaging collagen. And now I will talk a little bit more about why we actually are able to visualize collagen when we illuminate skin with linearly polarized light. The top layer returns single scattered photons, which are copolarized to the incident light. Now, as light propagates and being multiple scattered, it becomes randomly polarized. So on average, we can say that we have half of the photons copolarized and half of the photons cross-polarized to the incident light. Now, if we cross linear polarizer with the one that is attached to the ring illuminator, we will only be detecting the photons that propagated deep into the tissue. Now, how deep is defined by the optical properties, and in our particular case, it's the optical properties of epidermis and reticular dermis. And here on the left-hand side, you can see reduced scattering coefficient of the dermis and epidermis in green and red. And you also can see the depth of imaging, approximate depth of imaging shown with black curve, and it can be calculated as inverse of the reduced scattering coefficient of these tissues. And luckily for us, we can see that in the 400 nanometer range, this depth is approximately 100 to 130 microns, and that is exactly the depth underneath epidermis. So we are looking at the reticular dermis when we are imaging with blue light. So let me show you what actually we can see. So here you can see a digital photo of human skin. And if we take 410 nanometer image, that's what we will see. We will not see epidermis, we will see dermis, which is like this bright gauze-like structures, and in between you can see hair follicles. If we image at 440 nanometers, we have similar image, but it is a little brighter. The reason for it being brighter is that attenuation by melanin, which resides in epidermis, and blood, which resides in dermis, is a little lower. And it is also due to higher transmission of the fiber optic at 440 nanometers. Now, if we keep going further into the longer wavelengths, and we image at 570 nanometers, which corresponds to the oxyhemoglobin absorption band, we can already visualize blood, and you can see it's dark because it attenuates the signal. And then if we go even further into the red, we can see basically a diffuse image similar to the one that, grayscale, but similar to the one that is in color, because we are imaging quite deep and we don't resolve the structures any longer. So now we selected 440 nanometers for visualization of collagen. You could do other wavelengths such as 410, but for us that was the choice, primarily because the transmission was slightly better than at 410, and we had this filter already in our system. Now, what can we target? How can we look at skin, and what can we find out by imaging at 440 nanometers? First of all, we can look at collagen damage, and there are different types of damage. Mostly it's age-related changes which occur due to genetics and cumulative effects of sun exposure. And what you see would be the reduced density of collagen lattice and also decreased reflectivity of collagen. We could also look at tumor-induced changes, but that would be localized destruction of the collagen network. So we first started with the age-related changes, primarily because it is a very easy project to accomplish. IRB approval is quite easy. You don't have to deal with sick people. You have like basically healthy volunteers, and nobody said no to our suggestion of being imaged because it's really quick. It's not painful. It's even, some people say it's like spot treatment, and we could quickly enroll as many subjects as we needed. So, but the first thing we needed to prove even to ourselves that indeed we see collagen, and that indeed the images are similar to those that are acquired with confocal imaging. So for that, basically, I chose myself to be a guinea pig. So you can see at the top panel, the wide field OPI image of my skin, of my facial skin right by the ear. And then after the skin was imaged, a biopsy was taken by my collaborator, Dr. Neil, and skin was flipped and put on the confocal microscope and imaged from the dermal side using confocal imaging already in the infrared RCM, reflectance confocal microscope. And what you can see that the images are strikingly similar. There are bright collagen bundles, which are indicated with orange arrows. And what you see, the dark spots, are actually hair follicles. You can see the gray arrow pointing to the hair follicles. And similarly, you can see this hair follicles in the ex vivo dermal side imaged after the biopsy was taken. Now, we didn't need to take any more biopsies from anyone, and we enrolled 17 subjects and we imaged their collagen. So here you can see some example images. Here we have digital pictures of the 25-year-old subject, 35-year-old subject, and 65-year-old subjects. That is the top panel, the colored panel. And I hope you agree with me that it's hard to say who is younger from these pictures, just because of the skin types. The skin types are quite different. But when you look at the collagen, you can clearly see that younger subject has much brighter image and much denser collagen as compared to 35-year-old subject. And if we look at the 65-year-old subject, we can see one area where there is really a lot of degradation happened. However, I would like to attract your attention that even though the reflectivity is low, you can still see collagen in this darker area of the image. So it's not complete destruction of collagen, it just reduced density and reduced reflectivity. Now, the next step was to introduce some quantitative measures. Even for analysis of histology, pathologists try to look at the brown areas, which I've shown you, and in the previous slide of the immunohistochemical images of histology of human dermis, and calculate the area occupied by these brown spots so that they could quantify collagen content. So basically, we could do the same. We could do it by thresholding the image at a certain level and figuring out how much area is occupied by collagen. Then we also decided to look at the normalized mean pixel values of collagen, because clearly you can see that the images of younger subjects are on average brighter as compared to the older one. And then we also looked at the full width at half maximum of image histogram of the collagen bundles. So how can we do that? First, we need to introduce a calibrated reflectance reference into the field, and then it is a quite simple formula that can help us to calculate the absolute reflectivity of the region of interest. Here it's outlined with red square. Now, you can also see here that the field is not uniformly illuminated. This is in part due to the fact that human bodies are not completely flat, and also in part due to the fact that we have some variation in terms of how operator holds the system, and it's inevitable. If you are doing any clinical research, you will never be able to make it perfect like you are in the lab. So you have to be able to deal with the variable quality of the images. So what we did, we selected several regions of interest in the middle of our imaged field and analyzed those. So the first thing we did was we thresholded the image at about 35–40% of brightness, and then red areas would correspond to collagen and blue areas would correspond to other appendages of skin, such as, for example, hair. And here we can calculate collagen content, and we also can look at the size of the collagen bundles. When we look at the intensity histogram, we characterize full width at half maximum, and we also characterize the mean value of the histogram. So now you can see the same example subjects, and you can see by looking at the image histograms that the mean pixel values decrease as the age of the subject increases. So for the younger one, we have approximately 800 pixel value. For the middle-aged one, we have like 500, and then it goes to 450 or even less for a 65-year-old subject. And we can also see that the full width at half maximum becomes broader as the subject ages. So all these parameters can be used to quantify collagen structure, its content, and its reflectivity. Now let's go back to the previous structural slide on the collagen, and I've mentioned before that there are several ways to visually evaluate collagen, and those are provided by transmission electron microscopy, shown here. You can look at collagen fibrils. Immunohistochemical evaluation shows you some images of the collagen fiber, and then optical technologies show bundles of collagen fibers. So the next step was to compare the results that we obtained with the results that were obtained before us by other methods. And that's what we did. And you can see here on the left-hand side, the images delivered by OPI, or optical polarization images, then the images taken from the second harmonic generation study for the subjects of different ages, and then immunochemical images and transmission electron microscopy studies. If you look at the collagen bundles in the optical images, you can see clearly that there is more collagen bundles, both visualized by OPI and second harmonic generation. And there are more of those in the younger images or images of the younger subjects as compared to older ones. And reflectivity also is higher. Similar findings, but not that directly comparable, were found for histochemical and transmission electron microscopy study. So we have published these results of our pilot trial that involved 17 volunteers. We have proven that we can have the resolution down to 12 microns, and that doesn't restrict the field of view. The field of view was on the order of centimeters. So we can provide detailed information on the architecture of human skin. We also have proven that we can perform quantitative analysis, and that would quantify and enable non-invasive quantitative evaluation of collagen structure. We also have shown that whatever results we obtain, they are in concordance with the other visualization methods that were reported previously. The one thing that I would add now to what we emphasized in the paper is that we can also visualize blood, but for that we need to basically change the wavelength. We need to go into the yellow spectral range, and we need to actually sit on the hemoglobin absorption band to be able to see blood rather than collagen. Now, particularly useful, this kind of assessment obviously could be for evaluating cosmetic skin treatments. And that's basically what we have done. We looked at the pilot, we conducted pilot clinical trial with 8 volunteers, and we looked at the early improvement due to fractional laser treatment. So what is fractional laser treatment? It is a non-ablative fractional laser treatment, and it is characterized by creating small areas of thermally damaged tissue in epidermis and dermis. That way, bulk of the tissue is left intact and there is no downtime. But this kind of damage causes repair of the photo-damaged collagen network and stimulates collagen production. So, as was mentioned before, the most substantiated way to confirm that indeed these treatments cause improvement is ex vivo histological evaluation shown in this slide, but you can't perform this on the regular basis because the cause why people try to do this treatment is to improve the condition of their skin, so they would not want it to be biopsied. So another way would be to conduct a photographic study or evaluation, and it is in most cases quite subjective. It doesn't offer enough detail, and there is even such term as photographic cure, when you can cause a picture of a person to look as good as you would like or as bad as you would like it to be. So here is what we basically did. We looked at the collagen content or collagen density, because this is something that can be directly compared with histology. And the histograms were thresholded at 40% of intensity, and we imaged the subject before the treatment and then 2 weeks after the treatment. And we were able to monitor changes and collagen improvement. So now we needed to make a leap and kind of focus more on a more noble course, which is looking at preoperative delineation of non-melanoma skin cancers. And why I'm saying that it requires kind of a leap of faith is that because that is not obvious what we wanted to do. We basically want to look at localized destruction of collagen network by non-melanoma skin cancers. And that means that we would choose collagen disruption to serve as a biomarker of cancer, which is not that straightforward. But there are reports that tumors perturb dermal collagen by secreting protease enzymes and also by physically interrupting the matrix of collagen fibers. So now what we wanted to see if our optical polarization imaging can identify disruption of dermal collagen caused by non-melanoma skin cancers, and that if we can use it without disrupting clinical workflow to look at the clinical margins. Now, here is healthy collagen. That's how it can look. And now that's how collagen disruption looks in non-melanoma skin cancers. And I would like to attract your attention to the way the images look. As compared to aging, you have complete void of collagen structure where the tumor is present. It's just these very dark places. So that's what our hope was, that we will be able to see this disruption and that they will correspond to actual margins of the tumor. Now, why is this problem important? That's because non-melanoma skin cancers are very common. They're actually more common than all other forms of cancers combined. There are 5.4 million cases reported per year. And there are several ways to treat these cancers. Mostly they are treated by surgery. And there is conventional resection, which is performed without any margin control. And there is Mohs micrographic surgery, which is an ideal technology or ideal technique that is performed with intraoperative margin control. It is quite expensive. It is at least twice as expensive as a conventional resection. And after the first excision is done, intraoperative histology is processed and the surgeon knows if he needs to go back and excise more tissue. Interestingly, the error rate of visual determination of the margins pre-operatively is between 30 and 60%. So it's not that obvious where the cancer margins are. And obviously 30%, that's for the very well-trained and experienced surgeons, and 60% it's probably for those who are less experienced. Now, just to show you how bad it can be, so this is a picture before the surgery, and this purple marker identifies the margins by visual assessment by the surgeon, and that's the resulting surgical defect. After several stages of Mohs surgery, it can get even worse than that. Again, purple marker identifies the margins of the first cut. And here is the resulting surgical wound, which can be repaired afterwards, but of course there will be some scarring. Now, histology can be performed after the first cut, and then you can visualize collagen, and you can also visualize tumor cells using hematoxylin and nisin, and that can be done during the clinical trial to confirm or refute our hypothesis that we can preoperatively, without any excision, see the margins of the tumor based on the collagen destruction. So are there any other methods that have been tried for the same purpose? Yes, indeed there were and there are. It's confocal microscopy and optical coherence tomography. However, these devices have very small field of view and basically are quite complicated to. Personnel has to be trained to use these devices very well to be able to function. That's one bottleneck, and another one is interpretation of the images. It takes pathologists a long time to look at these images and figure out what they see. So on top of it, the devices are quite expensive. So now, what was our plan? Here on the left-hand side, you can see absorption coefficient of reticular dermis. That's where we aim to image. On the right-hand side, you can see a clinical photograph of the lesion. Purple dots are surgeon marker. So now if we image at 440 nanometer, we can see damage to the collagen by the tumor. And if we image at 640 nanometers, we can see surgeon's marker. And that's an amazing thing about optics. It's basically the same field, but by changing the wavelength, we completely change what we see in human skin. So now, first of all, we did some clinical pilot study of 6 cases, and we could see the potential for margin detection, but we realized quickly that additional image processing is needed, mostly due to the fact that unlike normal human skin, skin affected by cancer can also have some pigmented spots and some protruding blood vessels. So we need to take those into account so that they wouldn't confuse the surgeon or the person who is interpreting the image. For that, we basically introduce some spectral encoding or spectral analysis of the 2 images at 440 and 640 nanometers. And this is basically based on the fact that at 640 nanometer, we still can see blood and we still can see some pigmentation, but we already don't see collagen structure. And therefore, we can use image at 640 nanometer as a background image or a flat field image for our corrections. So now let me show you how it works. Here you can see a clinical picture with some lesion and also pigmentation spot and blood vessel, and experienced dermatologists can see it, but the image cannot. So now you can see our image without correction, and finally when we perform the correction, we can clean up the image. So we can remove basically the illumination gradient because it's the same, it's at 640 and 440 nanometers, and we can also remove blood vessels and pigmentation spots so that we can focus mostly on the lesion. Now, for the clinical trial, you can send the patient, you mark the lesion, or the surgeon marks the lesion. Basically, we don't have anything to do with that. Then we perform the images and the surgeon doesn't see these images. Now, what we do, we overlay the images and perform encoding and pseudocoloring. And that way we can see here that basically part of the tumor is outside the boundaries, imaging boundaries. Now, after the lesion is excised, histology is processed and a Mohs map is created, and it shows actually that there is some positive margin. It's shown with red here. You can see it in histology, and then due to orientation of the specimen, you can figure out where on the patient there is tumor still left. And you can see here that we were able to see this before, prior to the excision. So it's kind of like a blinded assessment. and Mohs map and our images correlate pretty well. So this was a trial of 53 cases. It is a quite small trial, but we had quite a range in the age of the patient. They were male and female patients. Locations of the tumor were different. And we looked at all kinds of basal cell carcinomas and squamous cell carcinomas. So interestingly, it was like a 25% error rate. So we calculated it by the number of cases where more than one Mohs stage was required to completely remove cancer. And OPI, optical polarization images, only registered one false positive. So even though the study was small, the sensitivity was 100% and specificity was 98%. So it definitely showed promise, and we were encouraged by this. And then we basically rebuilt our device to make sure that it's easier to handle, conducted additional pilot clinical trial at the University of Massachusetts Medical Center. We basically, that's an example image from that trial. And again, we had one false positive case, which demonstrated that still we need to take care of, in this particular case, blood vessels, which can be done by putting some pressure on the tumor while imaging, or incorporating additional wavelengths, such as 570 nanometers, to emphasize blood. So it will be not 2 wavelengths now, but 3 wavelengths imaging. And what now, here is the summary. We clearly could see that disruption of dermal collagen provides a reliable biomarker for skin cancer tumor boundaries, and we could even see that in superficial cancers. We could perform accurate in vivo preoperative delineation of the tumor margins, and it would take us approximately 10 to 15 minutes, which doesn't disrupt clinical workflow, which is important. So that means that this technology has potential to optimize treatments. And we are also looking now into monitoring radiation therapy for some types of skin cancer, such as lymphoma. And now we are working on further miniaturizing the device. You can see here a graduate student in the lab, Kate Mallory, and she's testing now this handheld, very small device. Basically, we're using a smartphone for imaging, and we just constructed some illuminating part of the device, which works together with a cell phone camera to look at the images. So that's our next step. So now I would like to acknowledge my former graduate students, Xin Fang, Rakesh Patel, Peter Germain, and Tyler Arizoa, my collaborators at Harvard Medical School, Dr. Victor Neal, Boyan Rohani, Tariq Shah, and Sherry Yu, and collaborators at the Department of Dermatology at UMass Medical, Basel Mahmoud, and Mary Maloney. I would also like to acknowledge funding sources. And thank you for your attention, and I will take questions now.
Yeah, thank you, Professor Yaroslavsky, for your talk. Please feel free to enter your question in the Q&A box. I have several questions in here, so I'm going to ask. So would you please comment on the use of different wavelengths? It seems that at a longer wavelengths, the image become blurry. Is that because of the polarization difference, or is it because of the optical cross-sectioning?
So basically, what is happening here is that polarization helps us to reject the top layer of skin. Basically, that's, let me get back to this.
I think it's slide 16 or 17.
Yeah. So now, so what we do here, we use cross-polarized light. And that means that every photon that comes from the top layer within first 100 microns for human skin will not be detected. Everything that will be detected will belong to reticular dermis, right? Or deeper.
Right.
So now 400 to 400, maybe 50 nanometer range will be exactly underneath the epidermis. So it will emphasize reticular dermis. As we move further, and that's what we see here, as we move further, we are already imaging deeper, which would correspond to the layer where there is more blood vessels, and also we have the thickness of the slice, so to say, would be thicker.
Yeah.
So due to the fact that blood is strongly attenuating both by scattering and absorption, we can still see blood here, right, at 570 nanometers. But as we go deeper, now our depth of imaging is approximately 250 microns and deeper. We can't resolve structures anymore.
So I wonder if you add a spacer or something on top of a scan, will that increase the contrast?
In which sense, like increase the contrast?
Because if you add a spacer on top of the scan, you're seeing the shallow layer of the scan.
So you mean we're squeezing the layer? Basically, we do have a spacer. And this is important for us because we want to keep the focal distance.
Yeah.
But it also helps us to couple light better into the tissue.
Okay.
So we use a gel like in ultrasound and a glass spacer to make sure that the light that is returning from inside the skin, not due to Fresnel reflections. In that sense, yes, we do use space, and we use a glass slide with a gel.
Oh,
yeah.
To flatten the surface.
Yeah, exactly right. It's exactly right. We do want to flatten the surface because you have seen that no matter how hard we try, we cannot make it absolutely flat.
Yeah. Understood. So again, we're open to questions to the general audience. Please feel free to enter your question in the Q&A box. Okay, I see we got a question here. I'll read it for you. Would a ring light illuminator with a narrow, near collimated beam be helpful versus a diffused light when entering the ring polarizer?
It's well, we basically are polarizing light as it gets out of the fiber optic ring light. So, and can you repeat the question, because I kind of didn't get it.
So basically the audience is asking about the light source. He's asking, or she is asking, whether using collimated beam would be better versus diffused light.
Well, yes, I believe that it would be better to have a collimated light, but it's in a way, by using the ring light guide, we make illumination uniform. So right now we are basically struggling to create uniform illumination using LEDs. The new device, the new smaller device uses LEDs, and we need to make sure that they overlap and that we create a uniform field, illumination field, because you don't want to measure differences in the pixel values due to uneven illumination, or you want to minimize that.
Yeah, we have several more questions. So one is, have you only used linear polarization?
Yes, we did use only linear polarization, and that's part of a reason why we don't want to make it too complicated. We know a lot of wonderful work done by Alex Vitkin and Tatiana Novikova, who are using all kinds of polarization, and they image Muller matrices of the tissue, and they're coming up with very comprehensive characterization of the tissue. Our goal is basically to provide clinical tool, and for a tool to be adopted clinically, there are several requirements, one of which is simplicity. It has to be very robust, very simple. It should not disrupt any workflow, and preferably should not require any retraining or any additional knowledge for the personnel to be able to interpret the images. So there are countless possibilities to use polarization and obtain information about human skin, right, or other organs. But we are focusing on a very clear clinical applications, and that's why we're using only linear polarized light.
Yeah, thank you, Professor. We get another question. So would you please comment on the general role of the ring, as well as how to manage the cross polarizations simultaneously? Also, regarding spectral encoding, how do you do that?
Okay, so I'm not quite sure I understood the first question, because you mean how do we calibrate cross polarization?
Yeah,
So basically what you need to do to make sure that your polarizers are crossed, you need to have some source of linear reflection, such as mirror. And that means that when you are perfectly cross-polarized, the mirror will look dark. And when you are co-polarized, it is bright. And that's how you can calibrate your system. It's pretty easy and can be done in a matter of minutes. With respect to the encoding, let me show you the slide, the respective slide, so that it's easier to follow what I will be saying. Sorry, I have to scroll. So basically what we do here, we acquire two images at 440 and 640 nanometers. Both images are cross-polarized, and that means that they are roughly from slightly different depths, right? What also is important that at 440 nanometer, the efficiency of the system is different as compared to 640. So different amount of light is transmitted. So we need to normalize the image to be able to subtract, or we can actually also use division. In the UMass medical trial, we use division method to correct for pigmentation, vascularization, and uneven illumination. So, and that's basically, I'm sorry, okay, actually, this is the formula. And that's what beta does. It is a ratio of the average pixel value at 640 to 440 nanometers. It makes the images comparable. What delta does is it accounts for some like hot spots, so to say, in the images. If I clearly see here in the photograph that this is a pigmentation spot, I can outline it and correct using the formula shown here. Correct for this specific spot. So that's basically what we're doing. It is similar to the flat field correction, or how do you say it better? It's not a flat field. There is a background image which contains pigmentation and blood, but doesn't contain collagen any longer. So we cannot see collagen at 640 nanometers, but we still can see pigmentation and blood, which has the same spatial distribution as at 440 nanometers. Therefore, by performing these arithmetic calculations, we can take or minimize the impact of pigmentation and hemoglobin in the image.
Thank you. We have another question here, generally about skin pathology and collagen disorder. So the audience asks, I was wondering if you had any thoughts about looking into the Ehlers-Danlos syndrome using this technique, since this is a connective tissue disorder that can affect collagen structure. For example, studying defects in type 5 collagen due to mutations in the COL5A1 gene.
Now, this is an excellent suggestion. There are many ways how we can use this technology to look at different pathological conditions, both in research setting and in clinical setting. Recently, we have built another system for Henry Ford Healthcare. They want to look at some skin conditions clinically using this device. And basically, if anybody is interested to conduct any kind of studies using this technology, you're welcome to contact me and I will help you in all possible ways to build the system. It is cheap, it is easy to use, so anybody can do that.
Yeah, it looks really promising with a simple setup and so capable of high resolution and larger field of view. I think I've run through all the questions on the list. Maybe I'll add a final question. Just thinking out loud, how would you envision, precision surgery with your imaging kind of on the flight and, with some precise surgery techniques such as laser ablation?
That's an excellent question. It would be my dream to combine this technology, which can be really small and acquires images in milliseconds, with laser surgery, so that we could kind of capture the image, figure out very quickly where the margins are, and then laser would automatically remove the tumor. That would be amazing, and that, I believe, can be implemented again very feasibly and very short term, very quickly. The only drawback of such approach would be that you can do it layer by layer. You can't also confirm that the tumor is completely gone, right? Mm-hmm. Because when you do it with a scalpel, you have a tissue and you can then analyze it. If you burn it with a laser, there is nothing to analyze. But there are definitely advantages to this, because lasers, they coagulate as they remove, so they cannot be bleeding. Probability of infection is very low, and definitely that seems to me as a scientist as a way to go, but we need to ask clinicians what they want.
Yeah, thank you, Professor. I think we've addressed all the questions, and thanks for your time.
Yeah, thank you for inviting me.
Thank you.